And just for a brief introduction, for those of you who may have just joined, my name is Alex Mitchell. I'm serving as co host tonight alongside Robin Hoyle, Executive Director of the Pain Societies that we're partnering with. I'm a communications manager with Lighthouse Lab Services, and it's been fantastic to sponsor these webinars in collaboration with the New York, Tennessee, and Pennsylvania Pain Societies and the Pain Society of the Carolinas. Um, we're going to go ahead and launch into our presentation tonight because I know it's one that everyone is interested in. We're covering toxicology, billing and coding, best practices, and things to know. And our speaker this evening is Ann Lambrix, who serves as the Vice President of RCM Solutions for Lighthouse. Just briefly on Ann's background, she's been heading up the RCM Consulting Division with Lighthouse since joining the company in 2021. Anne brings more than 20 years of experience in the medical insurance and billing industry, and her experience provides her with an insightful analysis of revenue cycle and payer trends that are impacting reimbursement. Ms. Lambrix holds an MSJ in health and hospital law and is often called upon as a source for industry publications to provide expert commentary. So we're very fortunate to have her here with us this evening. And with that, I'm going to go ahead and turn things over to her.
Thank you,
Oh,
Alex.
actually,
We need okay,
actually,
yep.
Anne, I'm gonna cover one housekeeping slide real quick. I forgot I added this in here. Just so everyone knows, in case you're not familiar with this system, if you're experiencing any lag at all, you can close any apps you may have running in the background, increase your bandwidth a little bit. In case anybody didn't hear Robin say it up front, this webinar will be recorded. Tomorrow, anybody who's attended any of the 4 webinars in this series, you're going to receive an email from Robin with instructions on how to claim your CME credits, and then in addition, the webinar recordings in case you'd like to share them. So those will be coming. If you have questions, we're going to do a Q&A at the end, but you don't have to wait until the end to ask your questions. You can go ahead and drop those in the Q&A section or in the chat, and we'll convert them over to the Q&A. There are also, if you'd like to take the slides with you tonight, the slides are available under the handouts section as a PDF. And then we have a couple just polls to run during the webinar. Those are totally optional, just for engagement purposes. If you'd like to respond, if not, go ahead and X those out and you can continue on with the presentation. And with that, I will turn it over to Ms. Lambrix.
All right. Well, thanks, Alex. Thanks, Robin. I'm excited to be here tonight. I was telling Alex earlier because of this late webinar, I was able to get a lot done today. It's been quiet here. Talking about billing best practices for toxicology. Why would I be a subject matter expert? I think just to lay the foundation of um, what we do here at Lighthouse Labs in the Revenue Cycle Management Division. We work with labs all over the United States, like yourselves, and really have our role is to come in and help consult on, again, best practices. We come in and do audits and look for areas of opportunity. So we've learned a lot along the way, as far as really what would be best practices and what we want to do to make sure that you're set up for success. So let's talk about, tonight we're going to talk about front end processes, the importance of documentation. This is really key for toxicology, especially now. Keys for requisitions, your CPT, ICD-10 coding, internal and payer policies. So your internal documents and various payer policies that you need to be aware of, denial management, KPIs, and audits. So really fun stuff. All right, so front end processes. What drives billing and making sure our attempt to make sure that billing is correct. And again, we're setting our claim submission for success for payment. We want to make sure that there's a good workflow from building your rules within LAS and your interfaces, charge capture. So that means making sure your testing is moving through the LIS into, again, the interface into the billing platform. For toxicology, you're billing your presumptive and definitive. They will roll up into bundle codes. We'll talk about that in a little bit, but we want to make sure that those interfaces are are running, and they're correct, and the codes that you're putting on claims are correct and being submitted and accepted by the payer. Your requisitions have the appropriate order and information needed to document the claim, and you're getting the signatures, etc. And again, this is all part of billing compliance. So we want to make sure we're checking all the boxes there. So what you're submitting not only is correct for payment, but will protect you in case of a payer audit. Really, really important is documentation, and one of the things that we're seeing a lot these days, with urine drug screening, toxicology testing, is that payers are requesting information, the medical records, the clinical notes to review. And so this is, normal billing 101 is you have to have the documentation to support medical necessity. And so, the LCD, your local coverage determination, from your Medicare MAC, is very clear in what they're looking for as far as to support the order and the medical necessity of the test. I really encourage, I'm not going to read this word for word, but encourage, when you're setting up for your billing, even though this has nothing to do with the claim form and the CPT and the ICD-10, making sure that your ordering physicians are clear in their intent to order and why they're ordering. Again, the presumptive, and then when you get into the definitive why, we want to avoid, where we're ordering panels, the reflex testing, where it appears to the payer that we're ordering panels just because it's routine. There has to be well documented reason why. And I'm not a clinician. I'm not going to get into the real detail of that reason why. And again, that's why I point back to LCDs and payer policies that will really build that framework around what they're looking for. But when we see and do audits, really that's where we see some misses, is that intent to order and the reason why isn't well documented. So we want to make sure that you're very aware that even though this doesn't go out on a claim form, when you're submitting electronically to a payer, the documentation isn't included. And so, we run the risk if a payer denies and asks for records. So, like a CO16, additional information is needed. Um, or if a payer comes in and does an audit, they may do a post-payment review and send requests to review. We run the risk, if our documentation isn't good on the front end, when they request that information and you provide it to them, you run the risk of them wanting the money back. So it is imperative that there is an assessment and a QA process to review documentation and make sure that you're providing feedback to your ordering physicians what might need to be improved. Like I mentioned, when your documentation is poor, we risk takebacks. We're seeing, I blame the pandemic for a lot of things, but one of the things that we're noticing is attention from payers was diverted to other things. Just like internally, attention was diverted to, just testing the patients, getting claims out the door. And so there was somewhat of a pause in audits. There was somewhat of a pause in potential denial trends that we saw pre-pandemic. And what we're seeing is now that the pandemic is over, the CARES Act, the public health emergency is lifted. Payers are going back to performing their reviews and potential, again, takebacks, for claims that they may have paid. So that's what we again want to make sure that's tight on the front end, because you'll risk, just because you got paid on something doesn't mean it was right. We risk prepayment reviews. So many of you, again, it is certainly, payers will, if you are submitting poor documentation, payers may put you on prepayment review. There's risk of 100% denials and risk of loss of contract. So this isn't to scare anybody. This is a requirement and can be done and done well. What we saw is that the individuals submitting the documentation may not have submitted the complete record, or they submitted only the requisition in the final report. And so again, payers see these opportunities as ways to again put you into these denial patterns and prepayment, post payment review. And so again, we want to prevent that and make sure that you have a good documentation. And when documentation is to be submitted, the documentation is submitted in full. The requisition also, there needs to have clear evidence, patient identification, that the demographic information. What really is important, what we're seeing is this ordering physician signature is missing. So again, these are things that are important if documentation is requested. And again, when you're billing for your toxicology claims, the requisition is really important. It's important to review the design. It's important to make sure that it is it's capturing the required information. That way, when it is requested, it supports that intent to order. All right, so we talked about that front end piece with the documentation, the requisition. So let's get into the fun part with electronic, your LIS, so your laboratory information system and interfaces. It's really the data flow. And what we want to make sure is, you're reviewing and making sure that it's set appropriately within the LIS and it's flowing to correctly to your billing. So again, that would be the interface. I think it's important to make sure that you've got a fee schedule set. And so, what we recommend is you have a standard fee schedule for all payers. We don't want to have one fee schedule for Medicare and one fee schedule for Blue Cross and one fee schedule for Aetna. That is not considered best practice, and you run risk of pulling the wrong fee schedule for the wrong payer. Um, it really complicates things, and again, payers don't like that. We do recommend that you have a self-pay or cash fee schedule. And then, of course, you may have client bill fee schedules. So if you're working with, various clients, that it's a client bill back to them, and skilled nursing, where you might be client billing back to the actual client. You may have different fee schedules in place. So you want to make sure that the the interface and the feed that goes over to billing is pulling there's identifiers to pull the correct fee schedule. um, Patient demographics uh, is a problem with laboratory because you're ancillary. We do see where demographics may be missing or unclear. And so again, dependent on the type of laboratory you have, um, making sure that you're working with your ordering providers, be it of your physicians and your front end process for intake. If you're a physician owned laboratory or you're working with a POL, versus an independent lab or a reference lab where you're getting orders from many different clients. You identify what might be missing in that interface and working directly with the source, so that you can improve that patient demographic. We see this be one of the top denials with when you submit claims to payers, is that the demographic information that was provided was incorrect. It termed, the effective date wasn't valid. And so this is really important, and there are many different uh, uh, technologies that can help support and help you get clean demographics, so that when you submit the claim, it goes through the payer, and again, you want to improve that collection activity. So again, as we mentioned, you want to make sure your charges are mapped correctly for each payer. So dependent on the payer, you may have, we're going to talk a minute about CPT codes, but with some payers, they want exploded versus the bundled CPT code or HCPC code. If you are um, um, uh, changing any code based on payer, you want to make sure those are mapped correctly. And that again is all within that interface. And so when you go in and set up your billing, or if you're existing, if you are currently billing to payers, and this is something that should be probably reviewed yearly, if not more frequently, to make sure things are mapping. And we'll talk a little bit about denial trends too, things that you can identify that might be a sign that your interface is set up incorrectly. But these are things that really um, will be very important when billing to insurance, especially. All right, the fun CPT and ICD-10, I didn't put, I did. Okay, CPT versus HCPC. So for toxicology, we have the core codes, your 803 codes, and then the G codes. For presumptive testing, again, they're bundled codes. You have the 803, 05, 06, 07, and then the G0480 for definitive, G0480 through the G0483. And those are bundled codes, dependent on, again, the level of service. We do see, and Alex asked for example, and I wasn't able to find one. So my blanket answer is we do see occasionally where certain payers want, again, the exploded codes. And so um, it in my experience, it tends to be the management, the Medicaid, the state Medicaid plans that may not have adopted. HCPC is more of a CMS. I do see most payers wanting the HCPC, the bundled code. But again, looking at denials, if you're billing the bundled code and there's certain denials that might indicate that the payer wants the exploded code, that's something that you might need to evaluate. But most payers want those bundle codes for toxicology. I think ICD-10 is really important. CPT, relatively easy. GO480 is the 1 to 7 drug classes, and most payers will recognize GO480. Once you get the higher number of drug classes that are being tested, it's really important to look at payer policy to identify whether or not they feel the higher uh, the higher codes are medically necessary, the higher number of drug classes. But ICD-10, again, if you look at LCDs, Medicare policy, there is typically lists of diagnosis codes that will be deemed medically necessary. We really want to make sure the lab should not be changing diagnosis codes to get it through the system. It needs to come from your ordering physician, and really this gets into denial management and educating your ordering on and making sure that they understand what is deemed medically necessary for urine drug screening. um, Very, very important. Those codes indicate to the payer um, what is going on with the patient, and why the payer should recognize the procedure code that you're billing for and pay it. So again, when you're submitting claims, payers don't get your documentation. It's all sent electronically. Most, I mean, very few claims anymore are sent paper. Things are sent electronically. And so there's no documentation. There's no hard copy reports that are attached to explain this patient has X. They get a CPT code and they get a diagnosis code. And that has to tell, kind of really in a nutshell, the why we're testing, why this patient needs this test paid. So really important to understand the impact, especially with the ICD-10 codes, on your billing. This is claims are out the door, and hopefully getting paid by payers. But one of the things that we talk a lot about with our clients is making sure that they have billing policies in place, making sure that there is someone designated internally, or you work with a third party biller that helps you develop certain policies, so there's consistency that is applied for the various um, procedures that may take place with billing. Um, Patient billing policy. This is really important. Dependent on your status with a payer, you may be in or out of network. The patient may have an out of pocket expense. It's very, very important that if there's out of pocket expenses that are applied to the patient, that there's an attempt to bill and attempt to collect from that patient. You can once that patient is billed. After that, there's some ways that you can work with the patient if necessary. But that's what you want to develop, a patient billing policy, and that will protect you from the potential accusations of giving away services for free. So again, patient billing policy is something that we really recommend that you explore. Make sure that it's consistent across the board, what you're going to do with, again, denials, what you're going to do with patient out of pocket, how many statements you send, when write-ups can occur, if there's discounts, what those discounts look like. Because you want to make sure Ann Lambrix, who's working and answering the phones, is giving the same guidance that Alex Mitchell may give when he's filling in for you. You don't want Ann to give free services to her friends, and Alex give free services to certain clients for their patients. So it's really important that there's a patient billing policy set in place. um, Bad debt policy. What are you doing if the patient doesn't pay? Again, making sure that this is written down, and there's consistent processes. We're not only looking at bad debt and making sure that there is a compliant plan, but it's also important to understand, by client, if you're potentially getting um, you know a bad payer mix. Patients aren't paying. It's you're losing money. What is your adjustment write-off policy? And again, if you're working with the third-party biller, this is important to work with them. When can they adjust something off? When should they be writing something off? When should they stop attempting to collect from either the payer or the patient? Understanding this again and having a method in place is important for the management of your billing. And I always, always, always recommend utilizing good partners. And good partners, I'm not speaking of myself. I'm talking about your billing partners, billing and those that are involved in your revenue cycle management. If you're doing that internally, making sure that you have good people that understand, um, you know, the some of the complexities. I mean, toxicology billing isn't difficult, but there are some nuances to it that may be different than uh, uh, your other procedures that you may be billing for, or that the biller may be billing for. And so it's important that they understand some of those nuances. And if they don't, they're asking for help. They're coming to you and asking you to provide guidance, or they're reaching out to other individuals that may be able to support them. This will help you. Again, the policies aren't something that is certainly required. However, when you're billing either to patients or to insurance or even to clients, it helps you manage that process and keep a clean book of business. All right, payer policies and procedures. So you bill out GO 483. You have the diagnosis code that supports per the LCD, and um, you get a denial that's saying it's not medically necessary. Um, Payers, we would want them to all follow, the gold standard, which we would say is Medicare, but they don't. So payers, the commercial, the managed Medicare, the managed Medicaid plans can take Medicare's guidelines and develop either enhance them based on their own guidelines or completely develop something else. So just because Medicare pays something and considers something medically necessary, and again, I'm going to talk about GO 483, the 22 plus drug classes. Just because Medicare pays it doesn't mean that Humana will. And so it's important to understand your payer policies and procedures. And when you're billing insurance companies, you have this information loaded in your system. And so I talk about edits a lot. Like a billing system should be able to develop and identify flag when 22 plus drug classes come over for Humana. We know Humana commercial doesn't pay for a GO 483. They only recognize a GO 480. It should stop. Or again, you stop it even in the LIS. You stop it when it's ordered. And this is where it's really important to understand these payer and policies and procedures, because what you want to do is be able to prevent you from performing work that's never going to get paid. Educate. You want to make sure you're educating your ordering physicians, and also working with the payers on really if there is um, potential appeal of their policy, that you're working with the payer to do so. Um, so, like I said, understanding the payer policies and procedures is imperative, as well as your documentation, to ensure healthy billing, healthy revenue cycle for toxicology. Payer edits. I did want to mention payer edits because we did have a little snafu in July with toxicology billing, where Medicare, who administers the NCCI edits. So NCCI edits have been around forever. This wasn't a new thing, but what they did was in the June updates, they came out and said, we won't pay for a presumptive and definitive on the same day. And so there's a whole NCCI edit calculation that you do. And so when you build with the G code, you build for the definitive with a presumptive on the same day, it was going to edit out and deny. Well, then they came back and said, well, we'll pay. We just have to add a modifier. So, but we're not going to fix that until October 1st. So in the meantime, between July 1 and October 1, we're going to deny these, and you can appeal it, and you can hold claims. So big mess. But yay, um, they did overturn that. That is no longer the case. They will not, they removed that NCCI edit. We don't need to worry about adding a modifier. However, it's still a problem because Medicare isn't the only payer that utilizes NCCI. I'd say all of them do. It is a standard. So it's really looking at the various payers and making sure that they not only adopt it, well, that they adopted Medicare's stance on it, that they're not going to require a modifier. If the appeals needed, that again, you submit a complete, robust documentation package, so that again you can avoid those. But that those payer edits, that bundling code CO97 or PR97, that is payer edits. And again, when your billing system can be, you can get the NCCI edits, and you can program your system to capture when those codes are billed together. It'll flag and indicate that a modifier, it won't be paid separately, or modifiers needed. Prior authorization. Many payers require prior auth. I would say for toxicology, this is a sign that because you're out of network and they won't pay for your test. But that's again something to understand. What their policy is on prior authorization, and then again going into the payer policy on medical necessity and frequency of testing. All of these things, as you learn them, can be put on that front end billing, so that you can work on that front end and make sure that that's robust, and preventing the mess that can occur on the back end. Oh, denial management. This is my favorite thing. It really is. My love is the denial management. I'm crazy. And this is why I joke around like I'm prematurely aging, because denials are, they are a pain in the neck, but they to me give me the clues as to what might be happening incorrectly on the front end. I'll see a denial. I've been doing this long enough. I'll see a denial and go, up, I got a CO50. That means that this code, the payer saying it's not medically necessary. All right, I need to look at the policy. And sure enough, there's guidance that they don't pay the GO 483. And so then I work with my client to understand that and understand what they need to do on the front end to, again, avoid that denial. You may get, this is another thing that's going to be red flags to payers. You can't consistently bill above what they deem medically necessary. So medically necessary, when you're getting those denials, you need to nip it in the bud quickly. You consistently bill when a payer doesn't deem something medically necessary. Again, going back to the what may occur is the payer will put you on a prepayment review, potential 100% denial. So you really have to look for those not medically necessary, non-covered denials. Increase in documentation requests. Now, I will say, like, because of that NCCI edit issue, you've seen an increase in denial requests, and most likely that is what it is. Um, but again, it may be a red flag to something else. So make sure you're paying attention, and not only paying attention to those denial, the if you see an uptick in those denials, but you're also, again, when you're appealing, if you're appealing any of these denials for not medically necessary, non-covered, um, or they're asking for your documentation, this goes back to making sure that what they're requesting, you are providing, you're not submitting incomplete information, and that the documentation that you've submitted, uh, it supports the medical necessity of the testing and the reason why the number of drug classes ordered and tested for is supported within that documentation. Very, very important. Prior authorization, provider not eligible to perform service. That to me is a trigger. Are you participating with the plan? So, with toxicology, dependent on the type of laboratory that is running the tests, you may or may not be contracted with the payer. And so some payers will pay out of network, other payers will not. And so again, that's important for you to understand, because again, if you're billing a payer that won't pay you, you can't get in network with, it may be a decision to not do business with that client. It may not, although that work may need to be sent to Quest, for example. Some of our large national payers have exclusive agreements, and so it is important to understand. I think it's important to understand too the place of service. I didn't put this in there with participation. Place of service is important. Many payers will limit what is performed in an office setting to just the presumptive. So it's important to understand that. You may see that in the denials. And so when you're setting up, if you haven't started billing, you're just thinking of doing this, or you're new to this, that's something to consider too. Is the place of service? If I get a contract, is the place of service going to cover the type of testing that I'm performing at this location? Frequency limits exceed. If you're getting that type of denial, there's might be a policy dependent on, you may only be able to perform 12 presumptive or definitive tests within a year. So it might be something that you're going to have to track and make sure that you're not exceeding that. Or medically unlikely edits. So with toxicology, I don't see many MUEs, but this is something that's published data. Most payers follow it. And so again, this type of denial will trigger me to look at the frequency limitation within the payer policy, or the medically unlikely edit, how many units can be billed for this particular code. Now, with toxicology, remember, your codes are a bundled code. So it doesn't matter how many, well, it does for the G codes, but the G code will reflect the number. And so when you bill the number of units, it is one, because the code itself communicates to the payer how many. Services included in other service procedures. So we talked about NCCI edits and bundling. And again, up until July 1, this really wasn't an issue for tax. And so, and now it really shouldn't be an issue, but we're still seeing the fallout with all the various payers. So again, it's important to be looking at your denials and making sure that billing is appealing, making sure that the appeal is supportive and the documentation is good. because that's what I'm seeing is where it's not, and then it's putting us into this vicious circle with payers. They just keep asking for more and more documentation. One of the things we do for our clients is we manage billing KPIs and really look for trends. And this is something that I encourage for billing. If you're billing, again, patients, insurances, you can do this for client billing. Um, one of the key phrases, what gets measured gets managed. And so it's establishing some measurements, some key performance indicators or expectations allow for you to identify trends and issues sooner rather than later. And again, the goal is to set you up for success. We want to make sure that when you bill a claim, it's getting paid. It's getting paid what you expect you should get paid, and that your volume, again, going back into the very beginning, your interface, the charges that you perform, the services that you perform, the tests that are tested, that volume is translating correctly to the volume that is billed out. And so managing the KPIs, and I just put some top billing KPIs to target your clean claim first pass rate. If you have a low first pass rate, meaning going through the clearinghouse, they're rejecting back, something's wrong with your claim setup. So fields that are on the HICFA are off. There's missing information that's needed to get to the payer as a clean claim, and it's really important. There's guidance on setting up your claim form and the loops and segments that need to go into an electronic submission. Most payers have these guide. It's I think X12 format. It's 837, 835 files. Again, there is very clear guidance on what needs to go where when you're submitting claims. And so these claims go through a clearinghouse, and the clearinghouse will kick it back if it doesn't fit that standard and there's missing information. So that is where if you have or a low clean claim first pass rate, that'll be an indicator that something wrong in your setup, in your interface, when you're submitting the claim through the clearinghouse. Bad debt write-offs. How much are you, when you're not collecting, that's considered bad debt. So you've billed and the payer is denying or the patient isn't paying. So what is, if that starts to leap, um, that is again a problem. And I like to recommend that you look at this not only by, again, um, by payer, by month to month, but also potentially by client, because you may be getting, again, looking at your denial trends, you may be getting orders and performing work that won't get paid by payer. You have bad demographics that, the payer's denying, and there's nothing that the patient's out the door, you can't get good information. And so it's really managing those write-offs and making sure that you understand the root cause and how do we fix it. Gross collection rate. I always give out, this is a very basic formula. You take your average payments divided by your average charges, and it gives you a GCR. It just tells us on average how much you're collecting per dollar billed. And that can range dependent on the fee schedule that you have set up. But again, if you're managing that and you have a decent idea of what your GCR is, and you don't change your fee schedule, so you don't raise or lower your fee schedule, it stays consistent. If that GCR starts falling, really looking at why and understanding, what those impacts are. Net collection is you take out your adjustments. You have your gross charges, and then you have your adjustments. So those contractual adjustments will reduce that collectability, and then you'll have the net collections, what should be collected. So again, if my charge for an 80307 is $100, and the payer is contracted to pay me 50, the your G your and I get paid 50, then my net is 100%. Average price per session, average payment per session. I would even drill down to price. Price is probably going to be standard for you, but payment per session by payer, because again, you want to make sure that you're identifying. I look at these for clients month to month. I don't get too concerned if they deviate much month to month. I'm more concerned if they deviate for a period of 3 or more months and you don't see any rebound. So if they lower and you can explain it, and then you see a rebound the following month, a month or two, and you see a pickup, then all is well. But if you see a consistent trend that your average payment per session is going down, your gross collection rate's going down, bad debts are going up, you have a problem. Your denial rate, how often are you getting denied by test, by CPT, by client? um, Days in accounts receivable, days in AR is calculated. You want to see how long it's taking for your claims to collect, to get paid. And then I also look at percentage of AR greater than 90 and greater than 120. Knowing your payers, and again, if you're participating with payers, they may have language in their contracts that require them to pay you in so many days. If you're out of network with most of your payers, I'd say that, looking at your AR greater than 120 is probably more reasonable. But whatever you decide to do, you want to look at your aged AR, and you want to make sure that you're really tracking those variances month to month to ensure that you capture issues before they become a huge issue and you're writing off hundreds of thousands of dollars. And the pay ratio is something that we manage, and this is how often you're actually getting paid on a particular code by a particular payer. All right. And again, this is not an intent to scare anybody. I would say this to any specialty, anybody that's in the healthcare business right now, prepare for audits. And why? I explained that earlier. It's got nothing to do with toxicology necessarily. It has to do with payers are now more focused on something that they had been doing and paused. So if you're new to this business, audits are a piece of what we deal with in billing. And so it's nothing to be afraid of. It is just something that I always advise to prepare for. Payers, as we talked about, they expect you to understand the rules. So ways to identify those rules: look at your policy, build your edits in the system to capture those policies and identify areas of again opportunity on the front end, and minimize that risk there. Payers are making payment what they say is in good faith. So when I say in good faith, we can all roll their eyes. Okay, I'm not defending these payers. I am just telling you this is what they say. Medicare is what we call a pay and chase kind of payer. So they'll pay you, doesn't mean you get to keep it, unfortunately. And so, again, that's why I go back to making sure that you're prepared for those audits and that you have sound processes on the front end. You have sound policies on the front end with your billing policies, that you can show your due diligence to the payer and come out squeaky clean with an audit. We do see inaccurate payers make mistakes too. And so they're going to look for those mistakes, potential overpayments that they made. And they're also looking for these red flags. And so this is really important, I would say, in the toxicology world. When you're billing insurance, understand that they are looking for unbundling. So if a payer wants you to bill for that G code, which, as I've mentioned, 99% of them do. If a payer wants that and you start billing the 80,000 series, that's going to be a problem. If you're overcoding, so you're billing more than what was tested for. And the big thing right now is keep that overutilization. Be very aware of that. The again, GO 483. If that is really all you're billing for, you will be flagged for audit. And again, I don't want to scare anybody. This is just, again, the 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 basics of billing in this industry. And it's not just Tox that deals with this. It is, where we talk about this with primary care physicians with their E&M coding. I work with a lot of pathologists, and we talk about the prostate needle biopsies and your IHC stains. So again, payers are looking for these. And so when they start noticing a particular provider is overutilizing a service, it doesn't mean that you're doing anything incorrect. So I just want to make sure that everybody understands this. It doesn't mean that the patient may require this type of test. the number of tests that are ordered, the number of drug classes that are required to test for. It What's very important is that documentation supports that, and that the policy also is they're going to cover. All right. I think I 7:47, Alex.
Great on the timing, and we'll hop into Q&A here because there are some good ones. And I should mention, Anne is feeling just a touch under the weather tonight, so we really appreciate her giving us an hour of her time, and we gave her the night off from the camera duties. Unfortunately, I'm dealing with no such affliction, so you get to see my face. But diving in here, let me see here. There's a couple good ones I wanted to start with. Um, okay, so I think we got a couple questions related to LCDs, local coverage determinations, and I sometimes we're so well versed in this world that we gloss over and maybe go beyond the initial understanding. But where can somebody maybe track the toxicology portion of LCDs that may apply to their MAC? And then we also have another question that how does just medical necessity and good documentation differentiate from adhering to an LCD? Oh, I think you might have muted your mic there, and if you're answering.
I did, thank you. As far as tracking an LCD, I don't know if there's any tools necessary. Well, I do know there's various tools. Again, dependent on your billing platform, may tie in LCDs to certain CPT codes, HCPC codes, or diagnosis codes. I know we use Code Map. I've seen through AAPC, Codify, and you know, various other billing platforms will tie that. But you can pull up your individual Mac and go into their LCD policy. I think CMS.gov has a pretty user friendly toolbar that I just Google or enter in the urine drug screening, and you'll find that policy. Um, can you give me that question again
Yeah,
about
the
the
second
medical
piece.
necessity and
So
documentation?
yeah, just in general, how does medical necessity differ from adhering to an LCD?
It,
Obviously, one is a coverage determination, and then another is just good practice.
the LCD. So I like the LCD that Medicare provides because it gives clear guidance on what they deem medically necessary and the documentation requirements
I'm
for
gonna go
urine drug
downstairs.
screening. There is as far as medical policy, and just you know good documentation requirements. Again, it I think kind of goes hand. The LCD is it's the local coverage determination. It is the payer's policy as far as how they will process your claim and what they deem medically necessary. And so it it gives us visibility into what they're looking for. Um, but it doesn't necessarily mean that this is like you have to actually follow this word for word. It just helps us, provide that framework of what they're looking for, within the documentation.
Thank you, Anne.
Hopefully, I answered that. I don't know if I answered that
No,
right, but
no,
again,
it's
yeah.
yeah, two different things, and I think we just wanted to provide
Mhm.
some clarification. I think you did great there.
And it
Um,
dependent on your Mac. The LCD but I think for urine drug screening, it's consistent. The language is consistent. When you get into other types of testing, there may be variations, um, but most of the time, Medicare is very consistent in their LCD policy for specific types of testing. There's also article guidance. So the LCD kind of outlines medical necessity for the test, and the billing the article guidance gives you the guidance on the specific CPT, HCPC, and diagnosis codes. And they kind of talk about what they will cover and what they won't via the CPT and diagnosis codes, and that's through the article guidance.
well, thanks, Anne. And now when we talk about prior authorization, that obviously isn't always necessary and can be tricky for some procedures or services, I should say. Specifically, we have a question about getting prior authorization when performing a random urine drug screen for opioid therapy management. And now, of course, you said up front you're not a clinician, but do you have any experience or insight you can share with regard
I
to something like that?
I I would look at that, contact the payer, and understand what they're looking for prior auth. In my experience, the prior auth is simply a denial indicating that you're not authorized to do any service because you're out of network. I'm not saying that this is the case in every circumstance, but for a test like urine drug screen, this isn't a genetic test. This isn't technically a high cost test. So very few payers do I see actually have true prior auth processes or policies for urine drug screening.
Thanks for that clarification. We have a question here about when a payer's unresponsive. So, what suggestions do you have when a payer's investigations department is not responsive to repeated requests for clarification or information about why a lab may be in an audit? Will they typically be upfront about the reason you're being audited?
Not necessarily. Again, payers expect you to understand their policies, and so what my experience has been is there. I would really go back and audit the documentation that you've been submitting, and making sure that there is clear in outline of the number of drug classes, that the need for the number of drug classes that are being tested for. Um, as far as requesting for them to provide you guidance on what you should be doing, again, I go back to that. That's why they develop policy.
All right. Looking at another one here, and again, we're getting kind of deep in the weeds, so I know I'm putting you on the spot a little bit. And if our answer is a bit general for some of these specific questions, please feel free to reach out to Anne, and she'll do her best to provide a response. In the coming days. This is a situation where someone bills for three different labs, and UHC pays out of network for all of them, but they're most consistently requiring medical records for only one of the three locations. This individual bills the same way for all three labs, so she doesn't understand why one may be singled out more than the other when all three are out of network.
Yeah, I would, again. I don't know if you're billing. Um, Potentially, again, I look to those, the G, anything over a GO 480, dependent on policy, might flag a payer if you have, a frequency, or not a frequency, a utilization of one over the other in the lab, that you feel is getting more requests for documentation, diagnosis codes. Um, yeah, if that's something that you're interested in me exploring further, reach out.
Okay. And I think we'll go with just a couple more here before we wrap up. Um, This individual has noticed in recent months that UHC's drastically decreased reimbursement
Mhm.
for 80307, GO 480, and GO 481. In this instance, they're now paying about a third of what they were a few months ago. Um, they asked for more information from UHC about the issue, and UHC contends the claims are being processed correctly. Is that anything your clients have noticed or something you've seen as an industry trend?
No, I would, again, look to whether or not you're participating, have a contract with UHC, and if any amendment. UHC, I would say, tends to be the lowest. They have lower rates than average. And so it wouldn't surprise me if they've amended the agreement, they've lowered your rates. If you're out of network, there is the median rate that they're required to pay. But again, it might be something that's unique to your relationship with United Healthcare, either in or out of network.
Okay. And let's end with something about the NCCI edit, since that was a
Mm,
big issue and something that you mentioned quite prominently. This is a question about having trouble getting paid for the confirmation code for dates of service when the edit was in effect. This individual's worried that, or they're appealing those payments with BCBS of North Carolina, and they worry that they may be denied for timely filing.
mm,
Are you seeing any timely filing
mm.
issues
I
in
am
relation to
I
that?
am not. I would argue, like, again, I don't if their filing requirement was 90 days, like if you've submitted, like, so my guess is that they probably held claims because of the edit issue, which, that was a business decision. You can attempt to appeal that with the payer and let them know that you, because of this edit issue, instead of billing to get the denial and appealing, you held the claims until the edit was lifted, and see if that you can appeal to their good nature. Um, but yeah, I mean, if we're billing after timely filing to try to get around that edit, you know, um, you're going to have to hopefully you have a good relationship with the payer, that will help.
All right. Well, thank you, Anne. We got a few more questions that we weren't able to address, and like I said, if you would like to follow up with Anne directly, please utilize her email address right there. We've got just a couple minutes left. I'm gonna turn things over, or back over to Robin, I should say, for some closing thoughts.
Well, first of all, thank you. Thank you, Ann Lambrix. That was outstanding. What a great talk. And we will have it recorded. It was recorded, and we will have it available for you to share or for you to review again. A lot of good information. I just can't thank Lighthouse Lab Services enough for this past 4 credit hours over the last, what, 3 months did we do it, Alex? We had
Yes,
some really
right at
great.
the end of October, and then through tonight.
Yeah, and it's really been wonderful. I hope to do it again very soon in the near future with you all. And for everybody on this webinar tonight and everybody that has participated in the others, again, you will receive your information tomorrow on how to claim your credits. And then you will also get copies of these videos in case you wish to review during a cold, snowy night this winter or a rainy night if you're in the South. Thank you so much, everyone. Alex, Anne, thank you again. Happy, happy holidays. And here's to a healthy, happy, prosperous 2024. Good night,
Yay.
everybody.
Thank you. Bye
Good
bye.
good night.
Bye bye.